Hi everyone, thanks for watching this lecture. I'm Hongxi Chu, a Taiwanese board-certified veterinary pathologist. My expertise is on small animal pathology, laboratory animal pathology, and dedicated to disease diagnosis and reporting. The topic of this lecture is about autoimmune disease in dogs. Beauregard Animal Health Diagnosis Center provides animal disease diagnostic services, including PCR, pathology examination, endocrine test, microbial culture and antibiotic sensitivity test, allergy test, and also avian tests for pet birds and exotic pets. Beauregard Animal Health Diagnosis Center is accredited for BSL-2 laboratory and is the first ISO 17025 animal disease testing laboratory in Taiwan. The autoimmunity is breakdown of the immune system ability to discriminate between self and non-self. The body's immune system therefore mounts immune reaction against self-antigens with harmful effects to the individual. Tolerance is a state of unresponsiveness in which the lymphocytes remain alive but cannot exert effector functions against a particular antigen. Self-recognition includes central and peripheral tolerance. Lymphocytes with receptors specific for self-antigens are deleted at any early stage in lymphoid cell development. This process is called central tolerance and allows self-reactive B and T cell to be removed. Lymphocytes that do not receive survival signals will go to apoptosis. The subset of T cell receptors that receive the correct antigen signals will leave the thymus into circulation. When self-reactive T cell escape into peripheral tolerance ensures that they are deleted or become anergic. Peripheral tolerance can occur through one of three mechanisms, include induction of energy, deletion of autoreactive T cells by apoptosis, or development of induced regulatory T cells. Criteria for diagnosing an autoimmune disease including direct proof, such as the fact that the disease can be transferred through cell or autoantibodies. Indirect proof, such as in identifying the antigen, then isolating the homologous antigen in an animal model, and reproducing this disease through administration of the antigen. Isolating self-reactive antibodies or T lymphocytes. Circumstantial evidence such as familial occurrence, lymphocyte infiltrate, MHC association, and clinical improvement with immunosuppressive therapy. Pathogenetic mechanism of autoimmunity mediated by activation of CD4 positive lymphocytes. Self-reactive CD4 positive T lymphocytes secreted cytokines to activate helper T cell lymphocytes. Self-reactive B lymphocytes produce autoantibody and induce type 2 and type 3 hypersensitivity. Th1 lymphocytes secreted interferon gamma and induce type 4 immune reaction. The consequences include but not limited to lysis, phagocytosis, granulomatous inflammation. The cause of most autoimmune diseases remain unknown, as they often are multifactorial and have genetic and environmental components. This is the illustration about potential role of microbial infection in the pathogenesis of autoimmunity. Microbes can lead to autoimmunity by inappropriately activating cell-reactive lymphocytes or by activating lymphocytes that cannot distinguish between microbial peptides and self-peptides. By induction of co-stimulators on antigen-presenting cells or antigen-presenting cells presents microbial peptides that resemble self-antigen and activate T lymphocytes. The following are 5 commonly seen autoimmune diseases in dogs, including IMHA, SLE, IMPA, IBD, and KCS. The first disease I want to talk about is IMHA. IMHA is a condition characterized by increased destruction of RBC because of binding of immunoglobulin to RBC surface antigens, commonly primary or idiopathic in origin. Often affects particular breeds including Cocker Spaniels and other breeds. Most commonly affects middle-aged female dogs. Also occurs secondary to triggers such as infectious, inflammatory, and neoplastic diseases, drugs, and vaccines. When the body is correctly responding to an immune reaction, antibodies ensure an appropriate immune response while the complement system enhances the ability to antibodies and phagocytic cells to clear pathogens. IMHA is a type 2 immune reaction where antibody or complement formation against RBC causes accelerated cell destruction and subsequent anemia. High levels of antibodies induce activation of the complement system and formation of membrane-attacked complex. RBC destruction tends to be intravascular due to osmotic lysis. Macrophages within the spleen, liver, and other organs recognize the Fc portion of the antibodies and the C3b portion of complement bound to RBC and prematurely remove cells from circulation and destroy them. There are 4 mechanisms of IMHA are listed here. Anti-RBC antibodies bind RBC surface antigens, resulting in RBC opsonization by IgG and complement, and then phagocytosis and are digested by macrophages. Spherocytes form when the membrane of Ig immunoglobulin or C3b bound RBC are phagocytosized by macrophages without removing the entire RBC from circulation. Compared to normal RBC, spherocytes appear smaller, more eosinophilic, and like central pallor. RBC agglutination occurs when anti-RBC immunoglobulins bind multiple RBC at the same time. Anti-RBC antibodies bind RBC surface antigens, resulting in complement activation and formation of membrane-attacked complex. MAC form membrane pores, resulting in rupture of RBC and the release of hemoglobin into circulation. Goat cells are RBC membrane remnants that lack cytoplasm. Spherocyte and autoagglutination on blood smear evaluation may be observed. Common gross findings include icterus and splenomegaly. Dogs with IMHA also frequently develop an inflammatory leukocytosis and coagulation abnormal, including prolonged coagulation times, decreased plasma antithrombin concentration, thrombocytopenia, and the DIC. Intravascular hemolysis plays a relatively insignificant role in most cases of IMHA, but evidence of intravascular hemolysis is noted occasionally, presumably in those cases in which IgM and complement are major mediators of hemolysis. Here we can see numerous spherocyte, macroscopic autoagglutination, microscopic agglutination, and anemia with pale gingival mucosa could be noticed in the patient. The marked yellow discoloration of tissues most strikingly visible in the subcutaneous fat is from high concentration of serum bilirubin produced as a result of hemolytic anemia. In addition, we can see the increased size of spleen. Treatment relies on non-specific immune suppression by glucocorticoids to control autoimmune responses targeting RBC antigens. Immunosuppressive treatment is associated with a number of adverse effects, both by virtue of the drugs used and prolonged duration of treatment courses. Second-line drugs have been used for treatment of dogs with IMHA, including azathioprine, cyclosporine, and mycophenolate. For dogs, the standard recommended glucocorticoid therapy is oral prednisone or prednisolone at a starting dose of 2 mg per kilogram. Glucocorticoids alone may not be sufficient to control immune disease in patients with severe or refractory IMHA, even when glucocorticoids are initially effective. Unacceptable high dose with associated steroid side effects may be needed to maintain IMHA remission. In these circumstances, a second immunosuppressive agent is often added to the therapeutic regimen to either increase the chances of initial remission or enable more rapid tapering of steroid doses for patients experiencing unacceptable steroid side effects. Azathioprine is a purine synthase inhibitor that inhibits lymphocyte proliferation, has long been used to treat IMHA in dogs. Mycophenolate mofetil is another purine synthase inhibitor, has recently gained popularity for treatment of IMHA in dogs. Cyclosporine, which inhibits T cell function, seems to be the most potent immunosuppressive agent standard available for veterinary use. Regardless of the immunosuppressive drugs used, it is uncommon for patients with IMHA to respond to therapy in fewer than 5 to 10 days. In the meantime, aggressive supportive measures may be needed to maintain patient stability until immunosuppressive therapy takes effect. Mortality rate among dogs with IMHA continues to be high. Most deaths occurred within the first few months after presentation due to severe anemia, pulmonary thromboembolism, or euthanasia resulting from client intolerance of the high cost of therapy and drug side effects. Long-term prognosis after survival of the first months of treatment is fair. Relapse rates are about 20%. For most dogs, treatment can be discontinued within 6 to 12 months of presentation, although some require lifelong immunosuppressive therapy. The second disease is SLE, also known as lupus. The cause of SLE remains undetermined, although the presence of autoantibodies directed against a number of tissues and organs suggests that the underlying immunological abnormality is a failure to maintain self-tolerance. Immune dysregulation with abnormalities in both cellular and humoral immunity, including defective T lymphocyte suppressor function and cytokine dysregulation. The defective T lymphocyte suppression function may be caused by anti-T lymphocyte antibodies or primary suppressor T lymphocyte deficiency, may result in B lymphocyte hyperactivity and in the formation of autoantibodies to a variety of membrane and soluble antigens, including nucleic acids. And autoantibodies are also directed to organ-specific antigens, clotting factors, and cells. The anti-nuclear antibody titer should be positive. Although the autoantibodies can damage tissue, the principal mechanism of injury in SLE occurs via antigen-antibody binding and the disposition of the antigen-antibody complexes in a variety of tissues, including the skin. The deposition of these immune complexes, which in the skin occurs at the basement membrane and in the walls of dermal blood vessels, results in a type 3 hypersensitivity response. Skin lesions are highly variable and non-specific in SLE. The face, ears, and the digital extremities are frequently involved, and lesions include erythema, ulceration, and exfoliative dermatitis. The distribution of the lesions suggests that photosensitization may play a role in the lesion formation. The disposition of these immune complexes, which in the skin occurs at the basement membrane and involves of dermal blood vessels, results in a type 3 hypersensitivity response. Lesions are intensified by exposure to UV light. The enhanced damage may occur via UV-induced suppression of nuclear antigen on the keratinocyte surface, autoantibody binding to the newly expressed antigens with resultant keratinocyte damage, and release of keratinocyte cytokines. UV light may also act by inducing the expression of adhesion molecules, thus facilitating trafficking of leukocytes to the epidermis. Systemic signs are variable but can include polyarthritis, myositis, fever, anemia, and thrombocytopenia. Erythematous macules progress to polycyclic lesions with central flaccid vasculation, and peripheral erythema could be noticed. Skin lesions predominant on the ventral abdomen, medial thighs, and the axilla. In chronic disease, ulceration can become more prominent. Erosion at mucocutaneous junction can be seen in some dogs. Microscopic lesions include lymphohistiocytic interface dermatitis with basal cell apoptosis, pigmentary incontinence, and the presence of subepidermal vascularization. The basal cell degeneration and subepidermal vascularization can lead to formation of subepidermal vesicles, which can rapidly ulcerate and clot. Basement membrane thickening caused by accumulation of immune complex and immune complex vasculitis of small dermal vessels can also be seen. Marked basal keratinocyte apoptosis has caused a secondary cleft through the epidermal basal cell layer, which is typical of the disease. Lymphocytes infiltrate the basal layer and are associated with basal cell vascularization. Dermal lymphocytic inflammation can be mild, lacking a clear subepidermal band-like pattern, but lymphocytes are still observed in the basal epidermal layer in association with basal cell loss. Chronic lesions can develop epidermal hyperplasia, a prominent dermal infiltrate of lymphocytes and plasma cells, and thickening of basement membrane zone. A thorough systemic evaluation including CBC, serum biochemistry, urinalysis, UPC ratio, and an ANA test, and a cytological examination is recommended in patients suspected of having SLE. Most patients with SLE have an elevated ANA titer, although this may not always be observed. SLE treatments will vary depending on the affected organs, The goal of treatment is to reduce inflammation and suppress the immune response that is causing damage. NSAIDs, immunosuppressive drugs, will probably be used. Antibiotics and supplements, including vitamin B, vitamin E, and omega-3 fatty acids, may also be given. Treatment will depend on which body systems are affected. If the joints are inflamed, then rest and restricted activity is critical. If skin is sensitized to UV radiation, then protection from the sun will help prevent progression of skin lesions. If the kidneys are compromised, then modified high-quality prescription diet will likely be recommended. Dogs with SLE have a guarded prognosis. This is a devastating disease and one that can be difficult to treat. It is progressive and unpredictable. Dogs with this diagnosis require long-term treatment to decrease the immune response. Unfortunately, SLE can be fatal, even with aggressive treatment. Up to 40% of patients will pass away during the first year. Suppressing the immune system has potentially serious side effects, making both the disease and its treatment worrisome. The third disease is IMPA. Immune-mediated polyarthritis is an important condition to recognize in dogs. Treatment of IMPA is significantly different than treatment of many other conditions that may present with similar clinical signs, and protocols may vary between patients. Making an accurate diagnosis is critical. The most obvious clinical findings include reluctance to walk, altered gait or lameness, and multiple swollen painful joints. Dogs often have a stifled gait or appear to be walking on eggshells, and lameness may be present in different limbs at different times. Spinal pain due to inflammation of articular facet joints or concurrent meningitis may also be seen. Other clinical signs associated with IMPA may be less helpful in localizing the problem to the joints. These signs are sometimes the only ones observed in patients with IMPA. IMPA is typically defined by a synovial accumulation of immune complexes, which starts a cascade reaction that draws neutrophils into the joint. Some erosive forms of IMPA may also include T-cell mediated response directed against articular cartilage. Canine IMPA has often been classified into 4 types: idiopathic, secondary to a non-joint infection, secondary to gastrointestinal disease, and secondary to neoplasia. Primary IMPA describes idiopathic cases, secondary or reactive. IMPA describes any situation in which the immune complex formation can be attributed to an identified underlying problem outside of the joints. Regardless of the classification system used, distinguishing the type of IMPA may help clinicians carefully consider possible underlying causative conditions and generate appropriate diagnostic plans. When a dog presents with abnormal gait or lameness, the first step involving trying to determine whether the underlying problem involves the muscles, nervous system, other soft tissues, long bones, or joints. Even when the joints are clearly painful, other diagnostic differentials should be considered. Characteristics of IMPA, subset of polyarthropathies, including joint inflammation, lack of infection or neoplasia directly involving the joints, and a positive response to immunosuppressive therapy. Synovial fluid cytology evaluation is highly recommended in joint disease condition. This table lists the total protein, total nucleated cell counts, and cell population of each differential. The canine polyarthropathies differential diagnosis, including non-immune mediated causes, including DJD, hemorrhage, trauma, neoplasia, or gout, or infections. The immune-mediated arthritis might be primary, non-erosive, erosive, or secondary. Most IMPA cases are treated with immunosuppressive medications. However, these medications may be contraindicated for several diseases that present with similar signs, such as septic arthritis, or being unnecessary for some causes of secondary IMPA, such as those related to vaccines or common vector-borne diseases. Treatment include analgesia. For patients that present with joint pain, analgesic medications are indicated while awaiting test results to confirm the diagnosis. Although NSAIDs are among the most effective medications for many disorders associated with joint pain, they should mostly be avoided in cases for which IMPA is considered a likely differential diagnosis. If NSAIDs are used, a washout period of at least 48 hours should be observed before the administration of steroid medications. However, NSAID may be appropriate in cases in which the use of steroid is not anticipated, or when definitive treatment is delayed while waiting test results or completing a course of antibiotics for a non-joint infection. Other options for analgesia in outpatient cases might include opioids, gabapentin, or amantadine. Doxycycline trial. In many cases of polyarthritis secondary to vector-borne disease, such as Lyme disease or rickettsial infection, a positive response to doxycycline is expected within the first week of treatment. Therefore, if these conditions are diagnosed or highly suspected, the initial approach may consist of therapeutic trial limited to the analgesics and the doxycycline. The underlying disease. Control of the causative disease process is an important part of successfully treating many secondary IMPA cases. This may include discontinuing medication if a drug reaction is suspected, treating a non-joint infection with antibiotics, controlling concurrent gastrointestinal problems, or removing or treating neoplastic lesions. Some cases of secondary IMPA may resolve when the underlying immune trigger has resolved. Specifically, IMPA related to recent vaccination or sulfonamide administration has been reported to resolve in as little as 3 days without immunosuppressive therapy. It is also important to recognize that, as in many other immune-mediated diseases, an untreated underlying immune trigger may limit the effectiveness of immunosuppressive therapy in cases of IMPA. This table lists some immunosuppressive medications, including the dosage, possible side effects, and some comments about the drugs. The fourth disease is inflammatory bowel disease, IBD. IBD are the most common cause of chronic vomiting and diarrhea in dogs and cats. The term IBD is used to describe a group of conditions characterized by inflammation of the GI tract and persistent or recurrent GI signs. Diagnosis is made by biopsy. Breeds with a predilection for this disease include the Basenji and German Shepherd. The cause is unknown, but the presence of numerous lymphocytes and plasma cells suggests an immunologic problem. Malabsorption and chronic protein-losing enteropathy can result from the marked infiltrate of lymphocytes and plasma cells in the lamina propria. Factors currently believed to be associated with GI inflammation include genetics, the mucosal immune system, and immune responses, environmental factors, microbial factors. Clinical signs of IBD can include vomiting, diarrhea, melena, hematogasia, weight loss, and hyperexia to anorexia. Some patients also present with clinical signs of disease progression, such as subcutaneous edema, pleural effusion, and ascites associated with hypoalbumin due to a related protein-losing enteropathy. The presence of ongoing clinical signs lasting more than 3 weeks is the basis of classification of a chronic enteropathy. It is important to get a full history, which includes characterization of clinical signs, duration, diet, therapies, response to therapy. The diagnosis of IBD is primarily one of exclusion and requires elimination of IBD mimics through complete clinical examination, laboratory testing, and specialized instrumentation. A clinical diagnosis of IBD is based on presence of persistent GI signs, inability to identify enteropathogens or other causes of GI disease, histopathologic evidence of intestinal inflammation. In dogs, there are increased numbers of both B and T lymphocytes in the lamina propria of the small intestine. We can see the dog is thin, emaciated, and loss of subcutaneous adipose tissue. Endoscopy of the intestinal mucosa reveals irregular intestinal surface on the left, and the right one is the normal. Duodenal mucosa also contains lymphocytes, plasma cells, and macrophages, which within the intestinal villi. Enterocytes lining the villi are cuboidal and having a few intervening globular cells. Some regions of the small intestine have dilated crypts that contain the neutrophils and cell debris. The lamina propria is reddened with lymphocytes and plasma cells infiltration. Treatment includes diet. A positive response to a dietary trial allows the patient disease to be classified as food-responsive enteropathy, a term that includes both dietary allergy and intolerance. The primary option for a dietary trial is switching to a diet that leads to antigenetic modification. The diet must be palatable and introduced in a gradually increasing amount over 4 to 7 days. In dogs with food-responsive enteropathy, a clinical response is usually observed within 1 to 2 weeks of changing the diet. In one study, Dogs that responded to diet were younger and had higher serum albumin concentrations and predominant signs of logical diarrhea compared with dogs that did not respond to diet. Antibiotics. An antibiotic trial typically involves administration of tyrosine, oxytetracycline, or metronidazole. The patient is typically maintained on antibiotics for 28 days. If signs recurred after discontinuation of therapy, long-term antibiotic therapy is instituted with tyrosine. Anti-inflammatory and immunosuppressive therapy. Patients that did not respond to a diet or antibiotic trial are usually administered prednisolone or prednisone. However, as a side effect of glucocorticoids are usually more marked in large breed dogs than in small breeds, as the therapy may be combined with glucocorticoid treatment for a faster taper period in dogs weighing up 30 kg. If there is poor response to immunosuppression or relapse is seen after tapering, cyclosporine may be considered. Sulfasalazine and related drugs are often used in dogs with IBD. It's limited to the large intestine. However, because side effects including KCS tear production should be monitored regularly. The use of probiotics in patients with IBD may lead to some promising results, although there is still an insufficient number of large, multi-center, randomized, double-blind, placebo-controlled trials. The dosage of antibiotics and immunosuppressive drugs are listed in this table for your reference. The prognosis is generally good with a confirmed diagnosis of IBD. Once the appropriate drug or diet is determined, many dogs remain on these for life, although it may be possible to decrease the drug dosage over time. Occasionally, a dog will be able to stop drug therapy. Most dogs do well for many years, while others require alterations in therapy every few months. Unfortunately, a few dogs will fail to respond to treatment. Some severe forms of dog IBD will eventually progress to intestinal cancer. This finding is well documented in humans, and in recent years, it has also been shown to occur in dogs. And the last one disease is KCS. KCS or dry eye is an ocular condition commonly diagnosed in dogs. It is less common in other species. KCS results often from an inadequate quantity of tears or a deficient quality of tears. Tears are produced by the lacrimal gland or tear gland and the gland of the third eyelid. Tears are needed to provide lubrication and nutrition to the cornea, as well as remove debris and infectious agents from the eye. Here we can see their abundant mucoid discharge cover the surface of the eye. The most common cause of KCS in dogs is immune-mediated inflammation of the lacrimal glands. Other causes of KCS include but are not limited to congenital disease, infectious disease, neurologic deficiency, endocrine disease, or prolapsed gland of the third eyelid, radiation therapy near the eye, or drug toxicity, including the use of sulfa derivative medications. Certain breeds are more likely to develop KCS, suggesting there is a genetic basis. Commonly affected breeds are listed here for your reference. However, regardless of breed, any dog can be affected with KCS. The most common clinical signs of KCS include painful red eyes with thick mucoid discharge. Dry eye most commonly occurs in both eyes, and some animals may develop secondary corneal ulceration or bacterial conjunctivitis. Corneal ulceration with secondary infection can lead to loss of an eye. Chronic uncontrolled dry eye may also lead to corneal pigmentation, vascularization, and scarring, which may lead to visual impairment. Patient history and several important diagnostic tests are involved in the diagnosis of KCS. The most important test involves looking at the corneal surface cells and tear filmed with an instrument. Paper test strips called skimmer tear test strips may also be utilized to quantify tear production from both eyes. If the patient has a normal tear quantity but has clinical signs of KCS, the ophthalmologist may also perform the tear film breakup time test to support a diagnosis of a quantitative tear film deficiency. Treatment of KCS includes daily lifelong administration of topical tear stimulant medication. These medications reduce inflammation as well as stimulate natural tear production. They are typically administered 2 to 3 times daily and are safe to give long term. Specific dosing instructions will be made by the vet. Concurrent use of tear replacement lubricating drops may help improve comfort for many pets. The majority of dogs respond favorable to drops, but in severe cases of KCS that are poorly responsive to medical management, a surgical procedure called parotid duct transposition may be recommended. This procedure involves redirecting the parotid salivary duct from the mouth to the eye in order to provide salivary secretion to the cornea. Parotid duct transposition often results in a more comfortable patient with less chance of corneal ulceration. Cyclosporin inhibits proliferation of T helper and cytotoxic T cells in the lacrimal gland and allows normal lacrimation. Cyclosporin also acts as an anti-inflammatory, decreases pigmentation, normalizes global cell mucin secretion, and directly stimulates lacrimation. Tacrolimus has a similar but more potent mechanism of action compared with the cyclosporin. Pilocarpine is a parasympathetic upregulation parasympathetic receptor secondary to divination results in increased sensitivity of the lacrimal system to pilocarpine when compared with the rest of the body. Tear replacement therapy provides lubrication until tear stimulants are effective. Lifelong tear replacement therapy may be needed in dogs that never respond to cyclosporin or tacrolimus. These medications are available as solutions, gels, or ointments, and have a wide variety of constituents. Cellulose-based solution gels and vasolytic products are more viscous and have a slower evaporation time than artificial tear solutions. They require application Q4 to 6 hours. Examples of cellulose-based solution and vasolytic products are hydroxypropyl and hyaluronate respectively. Artificial tear formulations containing petrolatum, mineral oil, or lanolin are the most viscous products and provide long-term lubrication, but can result in debris accumulation. They are best suited for patients with lipid layer deficiencies. Lactothalmus owners who will be absent for long-term periods. A severe mucopurulent discharge suggests a secondary bacterial infection. Generally use a broad-spectrum ophthalmic antibiotics such as triple antibiotic ointment Q 6 to 8 hours for approximately 2 weeks. Anti-inflammatory agent therapy may be useful if conjunctival inflammation is severe, possibly occluding lacrimal excretory ducts. Corticosteroids can be used on a short-term basis. Discontinue if patient is non-responsive. Only consider using them, though, in animals with no uptake of fluorescent dye. Apply topical prednisolone acetate 1% or dexamethasone 0.1% topically Q 6 to 8 hours. Use caution when using topical corticosteroids because dogs with KCS can develop ulcerative keratitis, infections, and keratomalacia. Mucolytics. If a patient with KCS has copious mucopurulent discharge, acetylcysteine 5% is often administered. However, its use is not common due to its expense and toxicity to the epithelium. Early diagnosis with lifelong treatment as well as routine follow-up examinations is of paramount importance for patients with KCS. In the majority of dogs, prognosis can be excellent for long-term comfort and maintenance of vision. If KCS does not respond to medical therapy, the prognosis is worse for vision retention. In addition, most patients will require lifelong therapy with topical immunosuppressive medications. Dogs with a diagnosis of KCS should be evaluated every 6 to 12 months to assess effect of treatment and progression of disease. Really appreciate again for watching this lecture. If you have any question about this lecture, please feel free to contact us. Thank you.